So good afternoon. So we continue with glaucoma, and then we'll of course continue in the evening as well. So thank you for being here on this glaucoma hall. And we've talked about how it's diagnosed, but usually what happens is once it's diagnosed, there's a dilemma of what to do later. So this IC basically is going to focus on once you're sure it's a glaucoma diagnosis and you've started treatment, what next? Because unfortunately, those who are going to be doing glaucoma are going to be with these patients for the rest of at least the patient's lifetime. And our goal is not to reduce the pressure now, but to see that they've preserved visual function throughout their lifetime. And that's what we hope for. So this course would talk about what we do once we've diagnosed it and once we've started treatment. I would request the faculty to please come on board. Dr. Pandav is here. Thank you, sir. Dr. Vinay Nangia should be coming. Dr. Harsh. Dr. Rita. Sure. Sir, Dr. Harsh. Okay. Right. And instead of Dr. Mayuri, who couldn't make it at the last minute, we have Dr. Faisal. Faisal, would you like to come up? So Faisal is our assistant professor now. So I welcome you to the glaucoma fold, but he's been with us for the last 6 years with his PG and SRship. So we're very happy to have him along with us. And we do have a couple of minutes, but I'd also like to introduce Dr. Nagraj, who's here for the keynote, and he'll be talking of neuroprotection in glaucoma. But since the faculty has requested there are parallel sessions, we'll wind up the session with that. So I request the faculty to all keep to time, and we hope to finish by about 4:10 or 4:15 so that Dr. Nagraj has his keynote at the end. So I think it's nearly 3 and we can set the ball rolling. Pehla introduction, please, Dede. Can I have the first presentation, please? The introduction to the course. Introduction. एक presentation होगा introduction. So since the slides don't seem to have come from the preview room, and Dr. Pandav has his here, so I request Dr. Pandav to at least kickstart the instruction course, since we've all just been introduced as to what we are to do. So quick recap, Dr. Pandav will talk on which glaucomas are most blinding, and Dr. Nangia will follow that up with are there factors at baseline that tell us which are the glaucomas to take care of. And Dr. Rita will talk about what IOP is adequate and for whom. How do you know which patient needs what pressures? And then Faisal will talk about how I decide how often I should call back my patients. Dr. Harsh will tell us the best tools to monitor progression. And then we'll have a panel discussion with cases in the real world situation. So Dr. Pandav, sir.
Thank you, Dr. Sushmita, for including me into the program. And good afternoon, everybody. Which glaucoma are most blinding? I think that's what I'm going to talk to. Now, glaucoma is a potentially blinding condition, and if untreated, it would invariably lead to blindness. But with treatment, and in spite of all the efforts, actually, if you look at the WHO figures, of blindness, the 8% of blindness is caused by glaucoma. So that's quite a big number. When we talk the glaucoma-related blindness, all glaucoma are not equally blind, that we know. And some are more blinding as compared to the other glaucoma diseases. So phenotype is important, as the type of glaucoma is important. But there are other factors, because type is not the only thing, and there are many other environmental, socioeconomic factors, and availability of the medical care is also important. So delayed diagnosis, poor compliance, systemic conditions, and other social and economic circumstances, they can also contribute to glaucoma-related blindness. If you look at the estimated figures, we have about 5 million people blind now, and by 2040, this number is going to almost double. So it's very important to talk about the glaucoma-related blindness. I'm sure you will come across these figures in other speakers' talks also, so I'm skipping over that. But most important is that PSCG, the phenotype, that angle closure glaucoma, is very common in Asia, and by 2040, half of these glaucoma patients would be in the Asia. Overall blindness due to glaucoma would be in the Asian countries, and 87% of that angle closure disease would be in the Asian countries. So we are actually looking at a very high disease burden, especially of the angle closure glaucoma in the coming years. And in day-to-day practice, most of us we can say that half of our glaucoma patients are angle closure glaucoma patients. So majority of these individuals we will have to deal with. Glaucoma blindness in Asia is also again quite significant, and if you look at the proportion of the angle closure versus open angle, angle closure certainly is a big factor in causing angle blindness. So important thing to remember here is that PSCG is 3 times more blinding than open angle glaucoma, and we have a lot of PSCG in our community. So this is, I think, one factor which we should always remember when we are treating our glaucoma patients. So the lesson is angle closure glaucoma is very common. It is more blinding, and don't miss angle closure disease. I think if you can go home with this message and practice, our purpose is basically served. Another blinding condition is the pediatric glaucoma. The congenital glaucoma is not that common, but it tends to be severe, and especially if it's not treated in time. And we also have juvenile glaucoma and other glaucoma associated with other congenital malformations. The problem here is that because these are kids, and if you look at the number of blind years, then it's substantial. So that builds up a lot of, again, social and economic burden to the caregivers. Then secondary glaucomas tend to be, again, more blinding. Pseudoexfoliation is not listed here, but pseudoexfoliation glaucoma is like 2 times more blinding than POAG. As we also know the neovascular glaucoma, uveitic glaucoma, post-penetrating keratoplasty, post-complicated cataract surgery or retinal surgery, all these cases tend to be a little more refractory and difficult to treat. So blindness figures in NVG are quite high, and because this is partly because of glaucoma and also partly because the posterior segment disease itself that could lead to contribute towards blinding. And most of the NVG patients, when they come to us, they usually have very poor vision, and recovery is usually not that great. Same is the story with the post-PK glaucoma. Again, they are difficult to manage. And here again, there are 2 issues. One is the optic nerve, and the other is the cornea. So high pressure is detrimental to both. And so again, there's a high risk of these people going blind because of both of these factors. Then inflammatory glaucoma, again, is a very varied group. It could vary from mild limiting transient IOP rise like Washington-Schwarzman syndrome to very severe intractable glaucoma. So each individual would need individualized diagnosis and care, and often this is compounded by steroid response, so that also has to be kept in mind. So secondary glaucoma is actually marked by marked increase in elevation in intraocular pressure, which can happen high pressure in a very short span of time, and that would very quickly damage the optic nerve. So prompt diagnosis and treatment of glaucoma is, and of the underlying condition is really important in these situations. So to conclude, certain glaucoma phenotypes are more blinding than others. Prompt recognition and therapy can save vision. PACG is common and should always be kept in mind. Thank you.
So since Professor Pandav needs to go, we'll take a couple of questions for Dr. Pandav right now. So what do we do when we diagnose a glaucoma which we think is more blinding? Any questions? So sir, just for the to set the ball running, when you diagnose a glaucoma which we believe is more blinding, does that change the way you would treat it?
Absolutely. Like again,
I mean, in terms of, would you advise surgery earlier, or would you step up medications?
There are many factors. It depends on the phenotype, I said, but that's important. And it's also the extraneous factors like compliance or socioeconomic those things also matter, or the frequency of the follow-up or availability of the follow-up. So that will also decide the kind of therapy you will give. But I think if you look at certain phenotypes which are more blinding, like angle closure glaucoma, and we have seen the clinical practice that the angle closure disease is actually quite underdiagnosed. So even if you take care of that chunk, so half of your blinding glaucoma actually is taken care. And secondly, other phenotypes like pseudoexfoliation or pigmentary glaucoma, where the pressure really goes up, and in between period there may be actually normal pressure, so they are again missed. So again, it's part of the treating physician. He has to take that call that if you are doing a good slit examination, good clinical workup, basically you identify these cases and then you target your therapy, counsel your patients accordingly. And as I said, if some patient, if the therapy is not possible, then early surgery or lasers could also be instituted. So important thing is basically to recognize the condition, recognize the situations where person is more likely to lose vision, and take an appropriate action based on that.
So this is Professor Pandav is head of glaucoma at Chandigarh, and Dr. Meenakshi is here at the other tip of the country. So let's get a perspective from down south. If you see a glaucoma which you believe is going to be more blinding than your usual, what is your take? Because the setting would be different. Would you tell them that you might require early surgery or step-up treatment from, or you say we'll take it as it comes, and does it change your management and how we do it?
Very much the way Dr. Pandav said, it's just that we need to see as to how, is this patient likely to follow up or not? And are there going to be more gaps in the follow-up?
All right.
And also ensure that are we taking adequate measures to see whether the patient is progressing or not. So get the visual fields done frequently, get imaging done if it is going to corroborate or not corroborate. We get a lot of patients
so
who are
the
say,
visual
NRIs
fields
who
done more frequently is to sort of document that how they're progressing
yes,
and the rate
yes.
of progression.
Yes,
So that's a
yes.
point to take, that initially you would do a little more frequent fields to be sure that this glaucoma is progressing at this rate, and then sort of we can decide on the follow-ups and decide accordingly.
Yeah, because we have many of these patients who come back annually because they live abroad, and when they come back from the Gulf, they come for their follow-up. So we ensure that the whole thing is done. And maybe if they are progressing, we tend to take them up for a surgery at a much earlier stage.
Than we would have
and if
normally.
they are of the age group which has a concomitant cataract and is not getting treated, I would prefer to go in for a phacotrab early and ensure that they don't progress.
Dr. Harsh would like to, and I request all of you and encourage you to come up with real world situations, because this is situational IC. This is like what you do when you have the patient in front of you.
So precisely, everything rightly has been said. I just want to tell you what happens in our country. A patient with bilateral chronic angle closure, yeah, supposedly. So bilateral chronic angle closure on 2 medications, well controlled. So we thought everything is fine. And then he comes back around 9 months later, one eye is PL negative. So I was totally shocked. What the hell happened? He said, sir, there were riots. I could not get out of the house. I couldn't get the medication. Now this would never happen in open angle glaucoma. But like Pandav rightly pointed out, it will happen in chronic angle. So please, for chronic angle closure, if you have 2 symmetrical eyes which are a little bit advanced, think of doing surgery in one eye. Second thing, the same way another thing happened, another patient came back like that. And I said, what the hell happened? You were absolutely perfectly well controlled. And nobody could think, nahi, sir, medicine to ye dal rahe hain. They were putting the medicine regularly. Then suddenly the wife said, oh, we have been taking medicines from Bhagirath place. So that is a place where you can get Nike, Adidas from, those kind of things. They'll just stick a label on that. For a $1,000 drug, how difficult it is to put water in that and do that. So please tell all your patients in such situations to take medicines from a running store, from pharmacies which are usually dependent like that, and not some small drug stores.
I'd just like to make a point. I don't know how comfortable you find, but explaining the gravity of the situation to a patient who sees 6 by 6 has never had any problem, to say that you need to put this continuously and you can become blind and all that, how much it gets across, you need a lot of chair time to explain.
Yes, true. Thank you. And we move on to Dr. Nangia. Dr. Nangia is a leading glaucoma practitioner of our country. He's in Nagpur, and we've been sharing chair time together for many, many years now. So he'll tell us factors at baseline that can predict progression. So once we've made a diagnosis, are there factors within this cohort which can predict that, look, this guy is likely to progress?
Thank you very much, Shushmita, for having me here. And it was very good news that the course, this is an invited course. Everyone liked it last year very much, that she was invited again to run this course. And I'm going to talk to you on, are there factors at baseline that can predict glaucoma progression? It's a little bit of a difficult topic because there are so many parameters and so many risk factors that are involved in determining whether this patient is going to progress. So it's often hard to determine in a particular patient the course that glaucoma is going to take, and I think that happens to all of us when we have a patient sitting in front of us actually. How soon or how slow is it going to progress? And progression, however, I have learned, and all glaucoma specialists learn as they age and their hair grows white, that progression is a given. And one has to be really lucky, even while giving what we consider as adequate treatment, to identify a patient who does not progress over a period of time. Amongst the various parameters that constitute risk factors, I'm going to deal with a few. One of them is age. Second is pseudoexfoliation, disc hemorrhage, beta zone, translaminar cribrosa pressure differential, compliance, and of course there are other vascular parameters such as venous occlusion, very high intraocular pressure, cardiovascular factors actually. So go back to the Central India Eye and Medical Study, and we found that there was a strong correlation with age with the prevalence of glaucoma. And this is widely true for all other population-based studies as well. The prevalence in this study increased significantly with age, and for the study population of 40 plus years, the prevalence was 3.45%. For 50 plus years, it was 5.11%, and for 60 years and above, it was 7.5%, and with better diagnostic modalities, I always say that in a hall of 100 people, maybe there are 10 people who have glaucoma and a few more who are at risk or are glaucoma suspects actually. So as a corollary, we may suggest that age is also a risk factor, not only for development, but also for the progression of glaucoma actually. So pseudoexfoliation, diagnosis, the presence of higher baseline intraocular pressure and greater number of medications and worse baseline visual field mean deviation were significant risk factors for progression, but don't take everything as face value because everything goes together. And I think the first thing that happens is raised intraocular pressure. We did a study many years back, and we examined 113 eyes with pseudoexfoliation. The mean intraocular pressure was 16.6, and the range varied from 7 to 60. And of the 113 eyes, there were 16, just 14% who had an intraocular pressure at that time of more than 21 millimeters of mercury, and the mean intraocular pressure in eyes with more than 21 millimeters of mercury was 34 millimeters of mercury with a range of 22 to 6. So I think there's a thresholding that takes place in the evolution or staging of pseudoexfoliation. So when we segregated eyes with pseudoexfoliation on the pupillary margin, those eyes had a mean intraocular pressure of 38.5 millimeters of mercury, and those eyes that had pseudoexfoliation on corneal endothelium and in the angle had an intraocular pressure of 34.0 millimeters of mercury, indicating that if you see pseudoexfoliation on the pupillary margin or on the corneal endothelium, then surely this is a patient that has a very high risk factor, and you need to follow up and reassess and treat this patient even more aggressively actually. The other risk factor is the presence of optic disc hemorrhages. They were only detected in 17 out of roughly 9,000 photographs, and the prevalence was just 0.19% in the Central India Eye and Medical Study. They were found to correlate with older age, higher systolic blood pressure, arterial hypertension, diabetes mellitus, even myopic refractive error, along with neuroretinal rim area, retinal nerve fiber layer cross-sectional area, and of course the presence of glaucomatous optic nerve damage actually. This is from another study from Zangwill from California, and the rates of retinal nerve fiber layer thinning was significantly faster in those quadrants that had disc hemorrhage compared to non-disc hemorrhage quadrants. So I think that's very important, that you need to follow up these patients. It's actually easier to follow up the patients for progression because we know that segments and quadrants where you see a disc hemorrhage are likely to progress faster. With unchanged treatments, the rates of retinal nerve fiber loss in disc hemorrhage quadrants were much faster. And with intensified treatment, the rates of retinal nerve fiber layer in all quadrants with or without disc hemorrhage seemed sort of significantly reduced actually. So of course, disc hemorrhage is an indication for more aggressive intraocular pressure lowering actually. And these are some examples of disc hemorrhage, and you can see the disc hemorrhage in the right eye, the disc hemorrhage in the left eye. And this patient was pseudophakic in both eyes with pseudoexfoliation. The good thing about it is that there is no retinal nerve fiber layer loss. There is a dip here, but that is just a variation in the way that the retinal nerve fiber layer is distributed around the optic disc, but it's not really a retinal nerve fiber layer defect. So I think we're extremely fortunate to have detected this patient with disc hemorrhage. We know we're going to have to follow up this patient, and the patient has got pseudoexfoliation in addition and elevated intraocular pressures. And this is a patient who had disc hemorrhage in 2012. This is the left eye, and you can see the retinal nerve fiber layer is normal. And then in 2017, 5 years later, you have a broad wedge defect, and you have a significant retinal nerve fiber layer loss associated with the disc hemorrhage quadrant. And that just proves what the other study was trying to tell us actually. Beta zone is a region of parapapillary atrophy. It shows chorioretinal atrophy and visibility of the choroidal blood vessels and the sclera. And there are many studies that have suggested that in eyes that progressed, the neuroretinal rim was significantly smaller and beta zone was significantly larger. And that in patients that had a large beta zone, the expansion in the beta zone was also associated with the increasing loss of visual field, or that the presence of beta zone in that segment was associated with increasing visual field progression. But I think that there are many factors that we don't understand about the beta zone. For example, this is a patient that has got almost a 360 degrees beta zone, but the beta zone is not tremendous. There are some patients where you find a very wide beta zone, but that's not the case here. It's almost as if it's uniform right from superior to inferior, and there is 360 degrees retinal nerve fiber layer loss, although the loss is more in the superior and inferior quadrants. So here we are not able to say that there was beta zone in one quadrant and therefore there was increasing visual field loss in one quadrant. And there are many variations of the beta zone that we are still not able to understand and correlate with the retinal nerve fiber layer. However, it is important to understand that there is a beta zone in many eyes with glaucoma, but it's also important to understand that there are many eyes that do not have glaucoma that still have a beta zone. So I think we need to understand beta zone a little bit better, but for the time being, one must assume that it is a risk factor in glaucoma actually. The other important possible risk factor that has been spoken about is the translaminar cribrosa pressure differential that has been defined as the difference between the intraocular pressure minus the cerebrospinal fluid pressure. It's further considered that since the lamina cribrosa is considered to be the primary site of damage to the nerve fibers, the pressure zones around this may be very, very important in causing glaucomatous damage. We are not able to measure the CSF pressure or the pressure around the optic nerve, and that is where there is a little bit of difficulty in understanding this whole concept. But from various things we have learned, and also from population-based studies, for example, in the Central India Eye and Medical Study, the intraocular pressure in patients with glaucoma was 17 millimeters of mercury, and in the non-glaucomatous eyes it was 13.7. The CSF pressure in the glaucoma group was 7.6, which is much lower than the 10 millimeters of mercury in the non-glaucomatous group, and therefore the translaminar cribrosa pressure differential was almost 10 millimeters of mercury in the glaucoma group versus only 3.6 millimeters of mercury in the non-glaucomatous group, telling us that a lower translaminar cribrosa pressure differential was safeguarding the damage to the optic nerve in these patients. Non-compliance is important. We don't pay enough attention to it because it's really not exciting for us, but it is important. And we did a study, and I would just give you an example. In this patient where she had a non-compliance index of 33%, we just take it over the last 90 days, how many days she missed her drops, and we get the non-compliance index. And the non-compliance index had a negative correlation with visual acuity, with the nozzle touching of eyelashes, showing that these patients are not careful with how they put the drops, and a completely abnormal technique of drop installation. So these are the various risk factors that I think we should consider when we have a patient of glaucoma in front of us. Thank you very much for this opportunity.
Thank you, Dr. Nangia. I think since the first two talks we discussed and were similar, we'll carry on now to Dr. Rita. She'll talk to us about, we'll change gears a little bit. And now that we know that a higher pressure is pathognomonic or prognostic of progression, how do we decide what pressure is enough? So that's the next question that comes to our mind. A higher pressure denoting faster progression, but how much is high and what is low enough? So she's going to talk about how do we decide that for different patients. Dr. Rita is a very senior glaucoma specialist from Mumbai, and we've been on many, many ICs together. Good to have you again, ma'am. Thank you.
Yeah, thank you, Sushmita, and for having me on your course again this year, and good afternoon to all of you. It's nice to see after a lunch break in the middle of the afternoon to have such a hall full of people listening to a topic on glaucoma. But of course, I'm happy to be able to share my thoughts on what IOP is adequate for whom and how do I decide. In the last two talks, we've heard that there are different forms of and degrees of glaucoma. IOP does not figure in any definition. However, lowering of the IOP is the current treatment, and we've seen that that has been validated by many randomized controlled trials from sessions from morning on. We've only been listening to this. So how do you get to this magic number? Oh, it's not slide. I'm sorry. Sorry. So how do you get to this magic number, and what is this magic number? The magic number is the target IOP, or the pressure at which progression can be halted or lessened without compromising on the quality of life. It is dynamic, it has a range, it needs to be assessed from time to time, and it depends on many factors. Now, we've heard Dr. Pandav tell us about diseases that are more blinding and some diseases which are less blinding. So we know that you can have glaucoma in all kinds of forms. So you can look at these patients from A to C. There are patients all having glaucoma, but who are progressing at different rates. And we've also heard Dr. Dr. Nangia tell us all about what are the risk factors for progression. And therefore, if a person is progressing rapidly, naturally you've got to be a little more aggressive with his treatment. So we've got to have some kind of an algorithm to decide who is the person whom you are going to treat at what level, how aggressively, and where would you actually want his intraocular pressure to be. So the European Glaucoma Society has actually laid down very nice guidelines for us to follow. So it tells us that there are 5 factors that you actually need to look at. You need to look at the amount of glaucomatous damage that has happened to the patient. If the damage is very early, your target intraocular pressure can be relatively high as opposed to a very advanced damage where you know that your target intraocular pressure has to be low. Similarly, you look at the life expectancy of a patient. If you find out that you've got a very old patient, an 80-year-old patient or an 85-year-old patient who's got X amount of glaucoma, as compared to somebody who's 40 years old and who has the same amount of glaucoma, obviously the patient who's older can still tolerate higher pressure as compared to the patient who's younger, whom you would want to target at a much lower pressure. Same for the untreated intraocular pressure. If the pressure at which the damage has occurred is high, obviously the target intraocular pressure will also be relatively higher, and if the pressure at which the damage has occurred is low, your target will also be definitely much lower. And then you go on to additional risk factors which have all been mentioned. If there is presence of one or more risk factors in addition to just the intraocular pressure and the disc damage, you will want to keep the patient at a much lower intraocular pressure as compared to if there are lesser risk factors. And then we've heard about the rate of progression. So if you find out that there is a patient who's got a very rapid rate of progression, you will want to keep his target intraocular pressure to be much lower than somebody who's got pressures which are higher. Now let's look at various case scenarios. Now if, for instance, you consider this patient and you see this kind of a defect in a patient who's 45 years old as against a patient who's 65 years old as against a patient who's 85 years old. Consider that they all have the same defect. They have this little hemorrhage, disc hemorrhage that you have seen. You see that there is a notch. You see that you can see a very, very early perimetric defect in this patient, but they are of different ages. So obviously, if the pressures say were 24 at the time of presentation, in that old patient, you will be all right if you bring down the pressure by, say, just about 20%. You won't be very aggressive. But if this was a younger patient, you definitely be more aggressive. So the damage is the same, only the age is different. Even considering that, your target intraocular pressure will change. Now let's take this case. This is an 82-year-old patient who's been on his target intraocular pressure for the last 5 years on treatment. But he's hypertensive, and suddenly he comes to you with this disc hemorrhage. What do? Do you want to reduce his pressure more? You're going to wait and see how much more damage is going to happen, and then are you going to start acting? That is a question that you have to ask yourself. Now, because this patient is already 82 years of age, he's already on multiple medications with multiple comorbidities, you being very aggressive in your treatment is not going to help him very much in terms of compliance. So you have to balance the two. If you can add two drugs in one drop and increase the dosage of medication that you're giving him, that will probably be more helpful. Now let's look at this patient. You have a similar patient, one patient who has different damages in both of the eyes. So his intraocular pressure in one eye is 26 and is 21 in another eye. This is a 57-year-old male patient. You can even see that there is a difference in the disc damage that you see. Now what will you do? Obviously your target intraocular pressures for both the eyes are not going to be the same. So even in the same individual for two different eyes, you have to consider and think of two different target intraocular pressures. Or look at this. This is a disc hemorrhage with intraocular pressures of 24 millimeters in a 64-year-old female with very thin corneas. So the 24 millimeters of mercury is actually pretty high for this patient, and she's already got a disc hemorrhage. She's 64 years of age, but you know that she's going to progress. And she's got thin corneas, so one more risk factor for faster progression. The disc hemorrhage is another risk factor which is telling you that she's going to progress. So she's got lot of risk factors for progression, so you definitely want to bring her target on to low. This was what her perimetry and OCT look like. Now look at this patient who's got an intraocular pressure of 26 millimeters of mercury with diabetes and hypertension with normal corneas. What would you want to do? You can see that the discs are looking all right. She's just a simple ocular hypertensive, but you can see that the vessels are tortuous and that she has the risk factor of diabetes and hypertension. More than the fact that she's going to convert to glaucoma and she's going to lose vision because of glaucoma, you also got to think about vascular occlusions in such patients, and therefore you might want to bring the pressure low. What about this patient who's got an absolutely normal intraocular pressure but advanced disc defect? So this could be a normal tension glaucoma. You've got to rule out all other things before you conclude that it is normal tension glaucoma, and then of course target the pressure to be much lower. So you have to tailor treatment to likelihood of future future visual disability depending on the disease stage, risk factors for progression, patient's overall health status and life expectancy. Now you also got to remember that setting and achieving a target intraocular pressure provides an algorithm for management. The quality of life may be affected by the medication used. There may be a loss of visual field, there may be a loss of contrast sensitivity, there may be a loss of mobility, and there may be reduced night vision, all of which can actually give rise to a fall in the quality of life. Now, according to the stage of disease is another way in which you can actually target your intraocular pressure. So if you have an early disease, mid-teens is okay. If you have a moderate disease, low teens is okay. If you have advanced disease, then you'd want to get to episcleral venous pressure. And then of course you've got to know that IOP has many confounding factors, which also we have found out. That the corneal there is a diurnal variation in the IOP, that the corneal thickness and hysteresis gives rise to another completely different story. For lack of time, we'll just quickly run through these. That glaucoma with a high 5-year risk for progressive visual loss or a high 5-year risk for visual disability, you will reduce the pressure by at least 40%. In glaucomas with moderate risk for 5-year visual loss or glaucoma suspects with a high risk to progression, you'll reduce the intraocular pressure by 30%. In glaucoma suspects at moderate risk for visual loss, you'll reduce it by 20%. Glaucoma suspects with low risk for visual loss, you'll just monitor the intraocular pressure. So also glaucoma suspects with very low risk of visual loss. Aggressive therapy for lowering intraocular pressure has its own deterrents, the side effects, the compliance, the stress if a figure is shared with the patient, because he'll constantly be thinking that he's got to reach that figure. His quality of life gets affected because of that. And of course, the medico-legal consequences if the target is not reached in case the patient continues to progress. So how often should you reassess? A periodic reassessment is a must because target is dynamic. For a patient who progresses despite being on target, different causes need to be looked into: poor compliance, other systemic reasons. For the elderly who are stable on aggressive therapy, target can be raised or can be reduced. What parameters do you therefore monitor? Just one slide more. You got to monitor perimetry and imaging, because you know that you can find out whether the patient is progressing or not. So to conclude, for both POAG and PSEG, after an iridotomy, we know that in mild glaucoma, you could keep the IOP range between 15 and 17, for moderate between 12 and 15, and in the severe stages, 10 to 12, or episcleral venous pressure. Target is a useful concept, not rigid. There is significant individual variability in anatomical and physiological parameters and numerous other coexisting systemic diseases and medications. With an appropriate target intraocular pressure range and continuous reassessment, glaucoma progression can be considerably slowed down so that at most only a few loci show a change. Thank you.
Thank you, Dr. Rita. Dr. Faisal, if you're ready with your talk. So Dr. Faisal will tell us, now that we've decided this is the person who's dangerous and this much is the IOP I want, but then you can't keep calling them every week, so you need to judiciously space out your patients, and Faisal will go over. So while he's getting on, like I said before, I welcome Dr. Faisal to the glaucoma fraternity.
Thank you, ma'am, for invitation. Very good afternoon, everybody. I'll be discussing mainly on the follow-up schedules of the glaucoma patients. As we know, the regular follow-up is critical for the physician and the patient also to monitor the glaucoma's disease and adjust the therapy as required. What are the predictors of inconsistent follow-up? The studies have showed that lack of formal education, no use of prescribed medications, and false belief that once the follow-up is less important if the medication has been started. What are other factors for contributing for follow-up dropout? Low waiting hours, unfamiliarity with the necessary treatment duration, lack of knowledge regarding the permanency of the vision loss. So there is a mutual association between poor follow-up and the disease worsening. If the patient have very disease worsening, she or he might not be inclined to a regular follow-up. So then another important barrier is the asymmetric nature of the disease. Especially in our setting, in a rural background, the patient can negotiate with his rest of life with single seeing eye. And another issue is that sometimes you have detected the glaucoma, patient may have 6/6 or 6/9 vision. You have to very difficult to convince them to come for regular follow-up. So what are the purpose of the follow-up visit? Monitor the IOP, visual function, evaluation of the optic disc, and reassessment of the RNFL changes, so you can continue the same diagnosis or change the diagnosis or change the plan of action. So the interaction between the patient and the disease is unique for every patient. Management for each patient must always be individualized. So here is a glaucoma suspect patient. This is untreated patient following for the last 10 years without any field defect. In this case, in case of untreated patient, to see there is high risk or low risk. If there is high risk, if no high risk factor, you can follow this patient 6 to 24 monthly. If the patient has high risk parameters, then should be followed with 3 to 12 months. This is another case, the treated suspect in view of the risk factor. If the target IOP is achieved, then examination for every 3 to monthly, then a visual field evaluation 6 to 18 monthly. If the target IOP is not achieved and the risk factor is still present, then examination should be not more than 4 monthly. In case of POIG, if the target IUP is achieved, no progression, and the control was less than 6 monthly, then follow up the patient for every 6 monthly. If the control was achieved for more than last 6 months, then follow up yearly. If the target is not achieved and the patient is still progressing, then follow up for 1 to 2 months. If the target is not achieved and the patient is showing progression, then follow for 1 to 2 months. If the target is not achieved but patient does not show any kind of progression, then follow for 3 to 6 monthly. In case of NTG, we know that the worst visual acuity and the advanced field loss are the most risk factors for the further progression of the disease. These type of patients should follow 3 to 6 monthly. So we know that angle closure spectrum have the 50% of our burden. So the patient with primary angle closures should not be considered, never should not be considered cure after even a successful LPI. So if you want to observe a PSCS patient every 3 monthly for 1 year, then every 6 to 12 monthly. The important point is that should do a gonioscopy for every visit. In case of PSCS, the patient had undergone LI, then first after LI, the patient has to be followed for 1 week, 1 month, 2 months, and 6 months after LI, then 6 monthly for a year, then annually. And all the follow-up visits should include IOP and check the patency of the LI, gonioscopy, and dilated disc evaluation. Fundus imaging can do 2 to 3 years, visual field once in 2 years. In case of PSEG, the consensus is that if you've done the LI and started the treatment, you can follow the algorithm for primary open angle glaucoma. In case of exfoliation syndrome, we know that the syndrome can convert into exfoliation glaucoma in 15 to 30% of the cases. They should be followed every 6 to 12 monthly. Whereas in case of established exfoliation glaucoma, their nature is highly volatile and unpredictable course. Some patient may be benign, some other patient can rapidly progress, so they have to follow every 3 monthly with 6 monthly visual field evaluation. In case of PDS, the conversion rate is 23% at 15 years. Most important predictive factor is if the baseline IOP is more than 21 millimeter of mercury, they should be followed 4 to 6 monthly because most of these patients will present at the younger age group. In case of steroid-induced glaucoma, this is the steroid-induced case of glaucoma following for long times. If the patient is presented with the steroid, stop the steroid, give a time for off steroid. Like most of the time, the IOP will come down within 2 to 4 weeks. After that, if the IOP comes to a normal range, follow for another monthly for 2 months, then 3 monthly for another 6 weeks, 6 months, then 6 monthly. Even if the visual field is already happened, nothing to worry or don't be panic. If even simple stopping the steroid can maintain the non-progression of the visual field. If the IOP is not coming down, even after stopping the steroid, start with a single medication and follow accordingly. In case of angle recession, we know the high risk factors are presence of IFEMA, angle recession more than 180 degrees, or heavily pigmented trabecular meshwork, and high baseline IOP. These patients should lifelong follow-up. If the patient present immediately after trauma, can call back after the 3 weeks for fundus evaluation and angle to examine the angle. Then you can call monthly for 2 visits, then 3 monthly for another 2 visits, then 6 monthly you can follow. The patient has to be followed for the lifelong for the both eyes. In case of uveitic glaucoma, the thing is different, and because the most of the time, sometimes the patient can with very high pressure, sometimes next day the patient can with low IOP, depends upon the control of their ocular inflammation. The best way to tie up with our uveitis colleague and do a simultaneous follow-up, both clinic. In case of secondary glaucoma like JOG, NVG, eyes, and post-refractory glaucoma, they very often require surgery. No meaning for delaying the surgery because they are very high pressure glaucoma, most often require surgery. Then they can follow like your normal post-operative patient. So just I conclude, though the regular follow-up vital for the management, need to consider the patient disability, disease severity, and socio-economical parameters before scheduling a follow-up. The interaction between the patient and disease is unique for every patient, and follow-up for each patient must be always individualized. What I mean to say that there is no generalized concept. The patient should be individualized. Thank you.
Thank you, Faisal. We move on to, we would call our patients, as Faisal has said, according to their pressures and according to the phenotype of the glaucoma that they have. But then, how are you going to monitor their progression? How are you going to know whether the patient that you've called back needs a further follow-up, needs longer follow-up, or you need to call them back even further, even earlier? So the tools to monitor progression are another question. Do we follow them on visual fields? Do we follow them structurally? And if so, how long and how frequently? So Dr. Harsh needs no introduction, I'm sure, to any glaucoma session. He was in the RP Center and now has been practicing glaucoma for, I think, most of his life outside, and it's a privilege to have him on the course as always. Thank you, Dr. Harsh.
Thank you, Sushmita, for having me here. Okay, obviously, Vinay has already said that it's a progressive optic neuropathy, and you are going to lose cells as you age, and there will be some kind of progression anyway. But anyway, we have to figure that out, and we have to try and give a good function till the end of the life. And how do we monitor it? Obviously, you can have functional tools in which we have fields, or we have structural tools like disc photography, imaging, and but very, very important thing is many a times we just neglect the patient by itself, and they will be saying, sir, something is not right. I feel that things are going down, and we think that this old man is just grumbling here. But what basically happens is that the patients sometimes get a very good sense. So you also please have a look at what they are saying and see if the IOPs have started rising a little bit from the previous ones, and you would know that something is happening over there subtly. Obviously, this chart is age old, and we all know that in early stages the RNFL gets affected, then the disc and the visual fields, though sometimes the things can be other way around. So this is one patient that came to us, 620 microns, a 50-year-old male, all the pressures were between 20 and 24, OCT was normal, fields absolutely normal, disc is perfect, there is nothing over there. We said, okay, we'll just follow him up. And 1 year down the line, the first thing that changes is that there is a wedge defect. So the first dictum is true that it was an RNFL defect which came up. The disc is still very difficult to make out if there is a notch, the field is still normal, and obviously in OCT there is a progression. So yes, we do know that this can happen. The one to my mind, and especially if you are in a small setup, the best tool indeed is your mind and your brain and your eyes. So keep looking at the disc very, very importantly. Please dilate, have a look at the disc. That will give you most of the answers in the early stages. And if you like, we have already said if there is a disc hemorrhage, obviously you are worried. If there is a bearing of the circumlinear muscles, that means that some of the RNFL over there is dying. Again, if the wedge defect is there, the notch you are not going to miss. But if the wedge defect increases, you know that something is not right. If the rim is getting thinned out, again, if there is a notch which is occurring. Another very important thing which has been stressed, I'll stress again, please repeat your gonioscopies. That is also progression. If the angle is closing progressively, that means something is not right over there, and you have to take action over there. But the gold standard obviously is the visual fields, and you have to check for new defects, enlargement of pre-existing defects, and deepening of defects. And obviously there are a number of ways by which you can do it. The most easiest is just take out a number of printouts and check whether things are going down. Then came the glaucoma change probability analysis. The problem was that it was based on raw data which could be affected by learning curve, cataracts, and so on and so forth, so which was not very popular. Then came the GPAs, which was dependent on the deviation numerical plots. For this, you basically need two good visual fields. So we were discussing all the time, please do two fields which will give you symmetrical results so that we can have a good baseline, and everything else that you do will be taken up from there. And then you can feed it, and when you have many more examinations, the machine themselves will tell you that if there is a likely progression or there is a possible progression, and then you can really take it from there that yes, if there is a progression, we will act accordingly. And obviously VFI is also another indicator which takes into account both the primarily the central effects, and both the pattern and the total raw data also is taken into account, and this can really tell us the rate of progression. So that is one of the best indicators to gauge that what exactly is going to happen in the future and how aggressive should be with our system. So fields are really, really good. They are still our gold standard. The problem is learning effects. So again, you can delete the learning effects by having two baseline symmetrical fields. Long-term fluctuation is there, so you can have fields which improve, become worse in the middle, but we have to be careful again. Even in worsening fields, you must have two symmetrical worsening so that you know things are okay. If it's an already bad field, be very, very careful. Don't go on any PhD, MD and all that. Just take raw data and closely study step by step how much deviation is there at each point, and that will how much decibel power is there, and that will tell you where things are headed. And you have to look for other pathologies which could be there which are troubling us. So good baseline fields, two of them symmetrical, always confirm suspected progression. Clinical correlation is important. Another patient, 48-year-old male, came to us, myope, initially normal in 2008, was not on any treatment, then came when 2016, when mild changes have started occurring in both the eyes, put on one medication, disappeared for a year, the fields have become worse, and then again came yearly, religiously he comes, and again the fields have become progressively worse. And the OCT also shows us that there is a progressive worsening. But the discs in these cases are not so clearly defined, and though initially you can see that yes, the wedge defect is there, as in the current you see that the wedge defect has not really increased, whereas the fields have increased. So why does this happen? Usually in early disease, RGCs are lost, surrounding cells perceive the visual target and they report the target as being seen. So in visual fields, in very early things, there may be that the dead areas are still being seen and the visual field may be stable. And why function before structure? Already structurally advanced, in advanced cases the axons are dead, but they are still lying over there, and so they are perceived as being present. So there again you have to be really, really careful. But we have now OCT tools, again just like a GPA, they can give you p-values to show if there is a statistically significant change in the OCT itself. But again, and this Cirrus, these are Sushmita's slides themselves, they can also tell you trend of the RNFL thickness, trend of the cupping as well. And what she wrote in a paper was that yes, OCT was more useful to detect progression in early glaucoma. Again, as we showed you, in early changes, yes. In late changes, it may not be as good. Again, if to see an example, a difficult disc, many a times these myopic discs, difficult to know out what is happening. Visual field and OCT both look progressed, but when you really do an image quality analysis, you find and improve the image of the take up, you find that the downward slope is reverted back. Again, left eye disc looks normal over 5 years, visual field is stable, but then when you see at the baseline, you realize that the baseline is not the same and as what was, so there are no symmetrical baselines, plus the take-up factor over here is not good in the follow-up things. So you have to really chart out whether the OCT has been taken properly, whether the baseline was proper or not. Basically, progression is not easy to evaluate. Judge very, very carefully, do multiple tests to make sure that actually progression has occurred, because it will need a drastic action, either an increase in medication which may cost the patient a lot, plus, or you may have to do a surgery, which again is quite a drastic step. Both functional and structural progression may occur exclusive to each other. Poor concordance between structural and functional tools many a times, but for early stages we see that structure is good, so you can do a disc assessment, you can look at OCT, but for advanced cases I think the field will do the trick for us. Thank you very much.
I will now invite Dr. Sushmita. She's going to take us through some case discussions and so that there can be participation from everyone.
I think what we'll do is we'll take the cases and we'll do the panel at the same time. So we'll do the panel along with the cases, but I encourage you all to come in and give in your inputs and your thoughts as well. Next one. Yeah, so this is what we do in the real world. So this is the usual story. You have a 67-year-old man, pretty much straightforward, POAG in one eye, advanced in the other. And this is very common to have superior defects which are quite advanced, because the superior field does not seem to matter so much in reading, in going downstairs or anything. Inferior field defects we've seen come up and we diagnose them much better. So this is typical of, this is of course at presentation. ये थोड़ा सा वो कर सकते हैं focus, it's a little blurred to me, but anyway, so this is how they come. And since 13 years now, pretty much this is the VFI, which Dr. Harsh just showed, and this is the other eye. So pretty much in the straight line, there would be bumps and fluctuations. You have to take into account these old gentlemen. And he's managed on medications. Now, IOP reduction is the cornerstone, whether you do it with lasers or drugs or surgery, depending on what you want to do. And the questions, of course, which we've tried to address is how much is enough. But another question in our country and in our setting is, if it's enough, what is the cost of that IOP? So we've gone through, this is just a snapshot, early glaucomas, moderate and advanced. So of course, early glaucomas need lesser reduction and you need more reduction as you go along. So the endpoints we have are pressures, disease stability, and the progression that we've talked about. And another thing that is important is a quality of life. So even if you have pressures of 12 and there's no progression, and yet the patient can hardly tolerate those medications, then it's not going to do much good. So whether or not the reduction is commensurate with the disease severity, that's important, and whether the medications are tolerated well enough. So we've just heard that everybody is progressing, some just faster than the others, and we need to have them in the target range if we want to stop it. The optic disc status is one thing, but it's difficult to do. You need some imaging techniques because disc drawings are a very, very good tool, but reliable disc drawings are a problem, especially in a very busy clinic. So you can see it's pretty much evident that the inferior rim has thinned out over 5 years, but it's difficult to have it on just disc images. So the imaging, we have a GCA, we have the fields, and the quality of life is important. So you can see these patients, sometimes we don't look at these hypertrichosis, but believe me, sometimes you can have really, really long lashes with bimatoprost, and these are all ocular surface problems with medications. And there's no point in telling these patients that your disease is under control and there's no progression and I'm doing such a great job, because the fellow will say that, well, all that is fine, but I can hardly put in a drop because my eyes feel so bad. So sometimes, and this is one scenario, you have glaucoma. So this 14-year-old boy, VKC, on Ciplox D eye drops for 2 months. So Ciplox D, another one is Pyrimone. I have no financial disclosures and no financial other way around as well. But then what next? You have pressures of 36 and 24. And these are the discs. So 2 months and bad pressure rises. So let's take a call. Dr. Rita, what next? Can you just pass around the mic? ये वाले lights on कर दीजिए. Just ये वाले off है तो ठीक. We could have these lights on, please, because we'll just do the panel along with these cases. Or, yeah, mic दे दीजिए इनको, please.
Since we know that this patient has PKC and he's been on steroids, obviously he's a steroid responder. And we know that there are other means of treating VKC, so you have to somehow reduce the steroids, because unless you reduce the steroids, the glaucoma is just going to go on worsening. So you have to learn to reduce the steroids, make the patient comfortable on the VKC ground, give him anti-glaucoma medications to bring down his pressures at the same time. So once you reduce the steroids, the pressures will come down on their own. In addition to that, you'll have to start anti-glaucoma medications because you don't want the pressures to stay that high for even any more time because you don't want any more damage to happen.
Okay. Dr. Harsh, your take. 36, 24 pressures, discs reasonable?
Yeah, I think
But
absolutely
early,
correctly
yeah.
said. The first thing is to stop steroids.
Yeah.
And two most beautiful things with work in this thing is the tacrolimus ointment
Okay.
and cold fomentation. They are the
So
cornerstones.
tacrolimus ointment inside, on the lid?
Inside also and on top of the lids also.
Okay, but inside apparently it stings a lot. So there are some people who say that you just massage it on the skin
you
and
can
that's
do
enough.
that
so that's
as well,
one
but
point. Yeah.
most of our patients have never really
They
complained. I
never
think they're already so stuck up with this
All
big disease that, and yes, then again, obviously we will have to, the only important thing here is in the kids, you need not panic and bring down the pressure to too much.
Yeah.
You know, because otherwise people will think, oh, initial pressure 36, madam ne kaha tha, make it 12, make it 14, right? There's no panic about that. Kids usually do well. And if there's no advanced damage to begin with, you can bring it down 22, 24, and you'll be happy with that.
And another point here that these are small discs. So if you see the eye with the lesser pressure of 24, it's pretty much crowded. So it's very easy to miss the glaucomatous damage in this eye. So it's important to be very, very careful about it. There is an RNFL defect here actually, which has come up on this, and he has a significant visual field defect. So there is already functional damage which is never going to go away.
Education of
So-
the parents is important because
Yes.
they need to know that this pressure can harm because
Yeah.
they're only concerned about the comfort of the child.
True, true. That's a good point, that the parents need to be told that this was it. So, yeah.
Probably like to do is insist on making them understand that they should not use steroids, you know, off the counter, on,
yes.
off and on.
Yeah.
Because this is going to happen and they're going to think that the eye is going to get all right, so they continue to use steroids on their
And
own.
they respond so well to steroids.
Yeah,
anyway,
and it's like an OTC.
yeah. So, so one thought was, what if we just stop steroids? Because like Dr. Harsh said, they're young eyes, young discs, and they withstand pressures quite a bit. So without rather going for an overkill, suppose we just stopped it. And there was a study that we did, we published this in Journal of Glaucoma a couple of years ago. And 44% of our patients of steroid responders initially reverted on withdrawing steroids alone. And the damage has occurred, but it's very early glaucoma. And steroid-induced glaucoma is pressure dependent. So let's just stop steroids and watch. So we did. We shifted them all to non-steroidal anti-inflammatories and tear substitutes. The BCVA was 6.6. It remained the same. The IOP came down to 18 and 16 without medication, and he's now maintaining visual field and optic disc status. So in effect, even in a young patient with very, very early glaucomas, this 136 pressure sometimes may not cause all that much damage because we are a little safe in the sense of saying that glaucoma is a very slowly progressive and it requires time for damage to occur. So if you can just call them back a little more frequently, maybe 2 weeks at a time, of course, that thing of that's there in you, that the pressure is already 36. But then now we've started doing is just withdrawing steroids without putting them on medication, which also demonstrates to the parent that, look, I stopped the steroid and your pressure is fine. So then they know that the pressure has not got okay because Doc Saab has prescribed a drug. It has got okay because my steroid is not in there anymore. So in that way, it sort of helps us with the children. But of course, you need to wait on how much the disc damages and what you want to do and how long. But these children need to be, or these people need to be on follow-up for all the time. Okay, so this is case 2. This 62-year-old man, he just came last year with blurring of vision since 3 months, 6.6 both eyes, but 16 and 14 millimeters without drugs. He had a concave iris configuration. You can see that on the slit lamp thing. So the configuration was there, deep angles, patchy pigmentation, especially in the superior angle. So there is a little bit of here pigmentation, but it's patchy. It's not really the painted trabecular meshwork that we see with pigmentation, but advanced glaucomatous optic neuropathy. Now what next? He has no history of steroid, no trauma, no surgery, no uveitis, nothing, no family history. He just comes like this, 16, 14 pressures, and he just says there's a little bit of blurring or near or something which I can't. He's actually come for presbyopic glasses. And this is the disc that you see. Dr. Nangia, I'll ask you to take that.
We don't see this condition so much in the country. But is the patient myopic?
No,
And
No,
are there any
no, not
transillumination defects?
they weren't.
They weren't actually.
They weren't. But then
Okay.
transillumination
May
defects aren't there usually
May
in
not happen in
pigmented
dark eyes.
eyes. Yeah.
So I think we're thinking of pigmentary glaucoma actually
Okay.
with spikes of intraocular pressure, and also because you gave the game away by by the concave iris configuration
Yeah.
and the pigmentation actually.
Yeah,
So,
so this is just to demonstrate that there is this entity called burnt out pigmentary glaucoma. So it usually burns out in the 7th or 8th decade, they say, so 60 plus. If you have somebody who is diagnosed like this and comes with a disc like this, the point to understand is if it is burnt out pigmentary glaucoma, then the damage has occurred. Then it's not an ongoing thing, and it's not equivalent to the NTG probably, that you need to lower the pressure to below 14. It's okay, because even if it is NTG, it's a slowly progressive thing, to just follow him. Don't send him home. Watch him. If there is no progression, maybe you can explain to him that this is something which has happened when you were probably young, and maybe you could. Dr. Harsh, what would be your take? Would you tell them to come back, or would you start treatment at 16 pressures? I mean, of course the disc is damaged. Of course there'll be advanced field effects. There's no getting away from that. This is a glaucomatous optic disc, but then what would we do next? What would be your
Have you
take?
done a diurnal variation?
No, we haven't done
So
a
I think the
diurnal
first step
variation.
is to do a diurnal variation.
That's a good point. You could do a
And,
diurnal
what is the
variation, yes.
corneal thickness again?
The corneal thickness was normal. I haven't put it in there.
Okay,
was
so
normal.
if that is normal, but if
Yeah.
if any pressures are going even near to 20, I won't mind putting him on medication.
On one medication?
Yes,
even if,
definitely.
Okay. All right.
How about doing a PI?
Because it's burnt out, probably, doing a PI, because it's all gone. I mean, all that pigment, if that's what we are thinking of, but doing a PI at this stage, there's no more pigment to be released. You know, it's not the classical pigmentary glaucoma pigment, but it's patchy. And in any case, there is one report last year in that they randomized their pigment dispersion syndromes and followed them up for 5 years, randomized into PI and no PI, and it made no difference whether you did a PI or not. In fact, doing the PI caused that release of that rush of pigment and maybe caused a spike then. So, yeah,
I would also like to take the blood pressure of the patient
okay,
and calculate the ocular perfusion pressure.
all right.
And if the DPP is low, then I would think that that is what is contributing to this.
And then lower the pressure
Yes.
further. Okay.
And if I can also do an ocular blood flow and to see if the resistive index is high.
Okay.
And in that case, treat the patient.
And that case treated. So anyway, what we did was we just followed him up, and at least on the 6 monthly, but it's early days yet. There hasn't been any progression. Now remember, in these cases, progression has to be a functional progression because it's going to be on 10-2 fields. So he's maintained it as yet, but I'll take Dr. Harsh's point and maybe do a diurnal, because we could be missing a spike which we haven't seen in our clinic. Okay, so yeah, glaucoma, yes. Needs treatment, yes. And imaging, yes or no. So this 72-year-old POAG, following up since 2 years, 612 vision, 1620 on one drug. Glaucomatous optic neuropathy, I'm sorry the pictures aren't too good, but then the right one was worse compared to the left. And you can see that on the fields as well, that the right is worse. The visual field is apparently progressing. Now, if you look at it through the naked eye, it seems that it is progressing a bit, but the algorithm says no progression detected. So now what? Now you're not, at least I wasn't comfortable with looking at this. There seem to be far more black points here than there were at baseline, though our machine said no progression detected. Any PGs? So good point. Any PGs or fellows? Why do you think it's showing no progression? Anybody? I would love an answer. It's showing no progression because the machine is going to tell you progression only on the second reproducible time. So it's going to come up with progression only if it is there for 2 times, for 2 visits. So since this is the first visit of apparent worsening, so then the idea is not to jump the gun, but to do a repeat field. So these are real world situations, and even if it says no progression, have a suspicion in mind, because somebody who's been okay with his field test suddenly one day comes like this. So we need to have the second field in. So now we reviewed his baselines, and this was a period of time, unfortunately, when the OCT was not working. So these are things which will happen. Happens in institutions, in clinics, that suddenly your machines break down. We are lucky, we are fortunate that we also had the HRT. So there was a period of time when we were only doing HRTs because our OCT machine was under repair. And we fished out his discs, and this was in September, and this was in 2016. Now this is also, to me, looking progressing. And the HRT, you can see the amount of red there, the cups have enlarged. So what suspicion was there in your head, the baseline IOP was 24, now it is 16, ideally should be all right, but there is structural progression, and treatment for glaucoma is ongoing. So I just brought this in to show you that you will do a repeat fields, yes, to be sure that the fields are progressing. But if you have structure, and if your structure is showing a progression, then you're probably on the right path. That 16, though from 24 is almost 30%, but it's not good enough for him. So glaucoma is something about ongoing and resetting targets and doing this over and over again. I think we'll just take one more. I have to bring in my babies, because childhood glaucoma is actually where my heart is. So when you have children, remember it's not just the IOP. They're growing eyes, they're growing children, and you need to take care of them much, much more than just bother about IOP and progression and structure. So this is an example, and I've just brought this in to complete the picture that glaucoma diagnosed, treatment started, what next? Now in these children, glaucoma diagnosed, surgery done, pressure controlled. What next? This is Peter's with a central corneal scar, which is never going to go away because there's a Descemet's defect. Optical PK is difficult in children, very few and far between do it, and it requires much more input into it. So what we've started doing is giving these children an optical iridectomy. Remember, it's a total Peters here. So it's a totally white cornea in one eye, but this baby has received an optical iridectomy, and this year has started going to school, and she's 6/18 now. Similarly, this baby at 6 months, unilateral PCG, a combined done, pressures control, everything fine. But he's 660 with his glasses because it's -20. Now there's no way this unilateral -20 glass child is going to carry on with it. So you're fortunate when you have someone like Professor Jagatram, who is in the next room. You take the child to him and say, sir, iska lens dalo. So this boy got a -2 diopter lens, which was custom made for him, and he's 6'12" now and is in class 4. So you hold their hands for the rest of your life. Treatment started. What next is that you have to carry on with them forever. So I couldn't complete this without bringing the children in. So of course we need appropriate diagnosis, timely treatment, set judicious IOP targets, but glaucoma management is not only about the pressure, we need to monitor them for structure and function regularly. I'd love to have any other comments, because after that we have a very interesting keynote from Dr. Nagaraj. So he'll talk to us about neuroprotection, but any inputs, any other comments for the course? So thank you very much for being with us. And I now invite Dr. Nagaraj to give his keynote address, and then we'll wind up. Thank you.
So I would like to, first of all, thank Professor Natarajan and Dr. Kaushik for giving me this opportunity to present our work on glaucoma. So I'm going to switch gears. I'm not a clinician. I'm a PhD scientist working in a university. So I work with clinicians. And what I'm going to do is to show you some of our latest work in the next 10 minutes or so. How we have come up, it's a drug discovery kind of research, how we approach this from a pure biochemistry point of view. So I'm also thankful to Professor Natarajan for bringing me out of Denver, where I work, which is -2 or -4 in the midday temperature. Here it is balmy, 22 or 24 degrees. I'm very thankful for that. So enjoying the warmth. So this work was done in collaboration with a group in University of North Texas Health Science Center, Dr. Dorota Stankowska and Dr. Raghu Krishnamurthy, who are experts on neuroprotection in glaucoma. So I don't need to show you this slide probably. For many of you are clinicians here. Glaucoma is, I'll quickly run through a few points. It's a heterogeneous group of progressive optic neuropathies. Approximately 64 million people worldwide have this disease. This will increase to 76 million in 2020 and 120 million by 2040. Nearly 2 to 3 million Americans above the age of 40 have the disease. The number is expected to increase by more than double from 2010 to 2050. Many major risk factors, some of them are listed here: age, myopia, family history of glaucoma. We heard a lot about glaucoma since morning, so I don't need to go through the risk factors again. The main consequences of glaucoma is slow and progressive death of retinal ganglion cells, which Dr. Harsh Kumar just mentioned, and optic nerve damage and visual field loss, which could lead to blindness. What are the contributing factors for RGC death and optic nerve damage? It's the disruption of axonal transport, astrocyte proliferation and hypertrophy, extracellular matrix remodeling, excessive nitric oxide production, elevated glutamate concentration, and neutrophil deprivation. So also recently several papers have come out to show that crystallins, which are the proteins abundant in the lens, they play a role. They are associated with glaucomatous optic neuropathy. I'll show you in a moment how we approach this. So one of the crystallins in the lens and in our body is alpha B crystalline. Okay, so this is a protein which is also present in retinal ganglion cells. As I said, this is a major protein in the lens and retina. It's a chaperone protein. That means it doesn't allow other proteins to undergo denaturation in cells. It's also an anti-apoptotic protein. That means it prevents cell death. If you stain human healthy retina and compare with the glaucomatous retina, what you see that this crystalline protein is highly expressed in the nerve fiber layer and the outer nuclear layer, but it's almost completely absent in a glaucomatous eye. Right? So this is the ganglion cell layer here. You can see some of it is lighting up for crystallines. So it's completely absent in glaucomatous eye. This means what? So when we saw this, we wanted to understand this protein in the context of glaucoma. So what we then did was used an animal model, which is alpha B crystalline. This protein is knocked out from this animal. If you look at the RGC number in these animals, this is central retina and the peripheral retina. This is the wild type. That means that has this protein, and this is the knockout that doesn't have the protein. In both central and peripheral retina, this is a retinal flat mount and stained with a stain called BRIN3A. This is a transcription factor expressed in retinal ganglion cells. So what you see, each green dot is a ganglion cell. So if you see the central retina in the wild type, and the peripheral retina, there are lots of ganglion cells. But if you don't have this protein in the retina, you don't have as many ganglion cells. That means this crystalline protein is important for the survival of ganglion cells. Now we took a different an approach that we have been, this took us almost 6 years to develop. So there is a small segment of that crystalline protein that's enough to function, to have the two functions, that is the chaperone protein effect and also the anti-apoptotic effect of the protein. This is a segment of that protein from amino acid 73 to 92. So this we call, it's a patented peptide now, we call this peptane 1. So we use this peptide, or now I'm going to refer this as peptane 1 from now on. Now you can culture retinal ganglion cells, rat retinal ganglion cells, have them in culture and expose to hypoxia to induce death. Okay, so when you expose these cells to hypoxia, they die. This is the red dots are dead cells here. Now if you have our peptide, then you don't have the red dots at all. So we are just adding our peptide to cells that are growing in cell culture, and when those cells are exposed to hypoxia, these ganglion cells are protected by our peptide. Now, we also then asked, this is all cell culture, so what, right? So we took a rat, we can culture rat retinal, whole retina, that we call that retinal explants. Again, we can have the explants in normoxia or hypoxia. When you expose the explants to hypoxia, retina cells, the ganglion cells die. Again, we are staining the ganglion cells with BRIN3A. So the green dots are ganglion cells here. So normoxia, you can see there are lots of cells. This is a scrambled peptide. That means a control where it doesn't have the same effect that our peptide has. So that in the presence of that peptide, cells are dying. But if you have our peptide, peptane 1, not all cells are dying. You can see cells that are dying here are protected by our peptide. So our peptide is protecting in a ganglion cell culture and also in the retinal explants. So this led us to this study when Dr. Morrison developed this animal model for glaucoma. You can inject a hypertonic saline solution into the episcleral vein of the eye, and the intraocular pressure in these animals can raise to about 30 millimeter mercury, and you can keep these animals for a month or so. And then what we did was we injected our peptide 3 times a week at 100 micrograms per injection intraperitoneally. Mind you, this is not intravitreous. So this is intraperitoneally to test the concept whether this peptide can protect ganglion cells in the retina. So what we then did was to retrograde labeling of the ganglion cells by injecting fluorogold into the superior colliculus, and then you can, after 3 months of the injection, you can sacrifice the animals and look at their retina. So the red dots here are the ganglion cells in the retina. So if you inject a scrambled peptide that is not functionally active, you can see when your IOP is elevated, the ganglion cells are dying. That is this death here. But if you have our peptide injected intraperitoneally into these animals, then you can protect the ganglion cells. So so we tested not only in cell culture and retinal explants, but also in one model of glaucoma. Now, what's even more striking, when I saw this, I was really shocked that this peptide, when we inject, in the same animals, if you look at the axons of the ganglion cells, we can label retinal ganglion axons with this paraphenyl diamine. So I don't know whether you can see from there these white dots here. By cannulating the anterior chamber with PBS, which is introduced to the anterior chamber through a reservoir which is kept at an at an elevation. So what happens then is the intraocular pressure raises to 70 millimeter mercury, and we keep that pressure for 60 minutes and take out the needle. So this causes massive reperfusion injury. So again, if you see central retina and the peripheral retina, this is central retina and the peripheral retina. If you inject the scrambled peptide, then the cells are dying here. So the peptide is ineffective. But if you inject our peptide into these animals, again intraperitoneally, this is not injected intravitreally. Intraperitoneally, it's protecting. Both, you can see here, the peptide is protecting the ganglion cell in this acute model. This is an acute model. We don't have to wait too long. 14 days after IR injury, we can see massive amounts of ganglion cells being gone from the retina. But our peptide is working even in this acute condition. If you look at the apoptosis of ganglion cells in the retina in these animals, after 14 days of this ischemic injury, this is a contralateral eye as the control. There is no dead cells. These are the green dots these are ganglion cells. They are dying by apoptosis. If you inject our peptide and stress these animals to IR stress, then they don't have no apoptosis at all, zero apoptosis. This was really, really surprising to us. A peptide injected intraperitoneally is protecting the ganglion cells in an acute model of ischemia. If you do the ERG on these animals, sorry, I skipped. ERG on these animals, you can see this scotopic ERG, A and B wave, both. This is reduced. This is the A wave. The red line is the ischemic injury to the retina reduced, and this is the B wave reduced. But if you inject our peptide to these animals intraperitoneally, this curve shifts upwards. That means the retina is protected. Both the photoreceptor cells and bipolar cells are protected. The one last experiment that we did, this is even more surprising to us. This is the axonal transport. So in the basic science world, the axonal transport has become a real big thing in glaucoma research, with how to protect the axons of the ganglion cells. So again, we have the scrambled peptide and the real peptide. We are now injecting a chlorotoxin subunit B into the vitreous of the ischemic retina to see how far the chlorotoxin travels along the axis of the ganglion cells. So this is done after 2 days after injection of the chlorotoxin to the eye. So you can see it's obviously labeled with the fluorescence dye. If you have the scrambled peptide, this is from the eye to the brain here. This is not traveling much. But if you have our peptide injected into the eye, then the axon is protected. You can see this dye is traveling well along the axon. So again, telling us our peptide is very effective against ganglion cell, both the soma and the axon transport defects that you see. It can protect both of those. Now, I told you we are injecting the drug into the intraperitoneal cavity. How do we know that it goes to the retina, right? A lot of people question this. It's a small peptide. It should be taken up by the liver and metabolized within minutes. But it turns out this one goes to the retina. If you do a flat mount, this is the serum concentration of the peptide in the retina. You can see within 3 hours it comes down, peaks at about 1 hour. But if you take out the retina and do a flat mount, you can see the retina is fully, it's in the retina, it's distributed throughout. If you do a cross section of the retina, you can see our peptide gets distributed across the retina and somewhat some in the ganglion cells as well. So we know that the intraperitoneally injected peptide crosses the blood retinal barrier, goes in the retina and protects ganglion cells. One last slide. So we are now working with a group of nanotechnology people to put this peptide in a nanoparticle solution and see whether we can subconj injection we can make it release on a sustainable manner, so we can prevent ganglion cells, at least in the acute models and also in the more recent model of glaucoma. So in summary and conclusion, peptide 1 crosses the blood-retinal barrier. This is the first for a peptide to have this property. It protects ganglion cells, axons in animal models of glaucoma. It improves the ERG response in the animal models of glaucoma. So peptide 1 could be a novel therapy against neuronal death in glaucoma. I find probably the best use for this peptide is probably the acute angle closure glaucoma and in traumatic eye and head injury. This could be very useful in these situations. So I just want to acknowledge the people who worked with me. These are the postdocs who worked with me for many years. Dr. Shruti Sampath Kumar, she did her MD here, and she came to my lab to work on this project. Dr. Meena Pancheva is our clinician. She helps me with clinical evaluations of our data. And this work was supported by Research to Prevent Blindness, New York. So with that I stop. And if you have any questions, you can answer. Thank you.
Can we, Professor, you know, most of us would not have followed many of the finer points because we're mainly clinicians actually. Could you just in very brief summarize the clinical importance of the research work that you have just spoken to us about actually?
Yeah, the ganglion cell death is a common occurrence in glaucoma, right? You lose ganglion cells. And so I heard this morning that if you lose 40% of the ganglion cells, you really have a problem. There's no turning back. So what we are trying to do is protect ganglion cells. If you detect glaucoma early on, can we protect ganglion cells and save vision, right? That's the whole basis for this research. So one of the things we are working on is with this peptide. We are working with other things as well, but this is very exciting because it protects both the soma part of the axon, the ganglion cell, and also the axons. So there are things. A lot of people have discovered a lot of things, but they mostly protect the soma of the ganglion cells, not the axons of the ganglion cells. So now the field has gone, initially 10 years ago, if you looked at glaucoma research, everything was focused on the soma part of the ganglion cells. Now people realize it's the axons that are more important. So our drug actually protects the axons as well as the soma of the ganglion cells. So we are trying to develop something to protect ganglion cells both at the front end of the ganglion cells and the back end of the ganglion cells.
And what you mentioned about it going through the peritoneum to the eyes was you were trying to say that you could take it systemically and that it would reach the retina. That's what you were trying to say actually.
Yeah, initially this was done as a, we were just testing whether this works or not.
Okay.
So intraperitoneally injected, but it worked. So we were surprised. A peptide can cross the blood-retinal barrier, which is very tight. Yes. Can cross the blood-retinal barrier, lodge in the retina, and protect ganglion cells in acute models of glaucoma. Okay. You know, that was surprising to us. So it's not an ideal way to introduce drugs to the eye, but it works. But now we are working with nanogel technology people to see whether we can put this right in the eye so we can protect ganglion cells in a long manner, in a long sustained manner.
Thank you very much, Professor, for being here with us and for telling us all about your work. Thank you once again.
Thank you.
Well, I think we've come to the end of the session. I thank my faculty who've been here, and I thank the audience, as Dr. Rita said, on the post-lunch session. And Dr. Devan should be back, I think, with his next session. Though if he isn't here, we can carry on. So we can take more questions if any of you want any. But otherwise, thank you very much for being here.